This section is starting with respiratory illnesses, and so we'll start with Chapter 13 for asthma. So, asthma is the result of an abnormal immune response in the bronchial airways. 75% are considered uncontrolled asthmatics out there, and they do have recurring attacks every once in a while. It's the narrowing of the trachea, bronchi, and bronchioles of the lungs by triggers, and that is what the chief concern is, if they're going to come across a trigger which is going to affect the lungs. Recurring attacks of dyspnea, which is difficulty breathing, wheezing, coughing, and chest tightness. Episodes vary in frequency, how long they last, the duration, and the degree of symptoms that they may have, depending on the person. So not all asthmatics are equal. The total obstruction of an airway is called status asthmaticus. I would know that, and that's when it's extremely serious, obviously, if it's the total obstruction, and you can die rather quickly. Asthma affects 1 of 4 urban children. It affects males more than females during the ages of 0 to 17 years old. And then it turns around and affects females more than males from 17 on. So asthma can be influenced by multiple genetic factors, developmental factors, and environmental factors. No two asthmatics are alike. They differ in whether it's genetic or environmental, or they just developed it and it was not genetic at all. So in the dental office, which is what we're concerned with, when we see asthma in there, it's usually stress-induced, or they have an allergic response to some type of dental material that we have in there, and that is often the etiology or cause of the asthma attack. Some prime things that could cause an asthma attack would be eugenol, impression material, resins, and latex. So we've pretty much done away with only using latex gloves. Most offices will have latex and non-latex now, but they are starting to make other products without latex. For instance, this little stopper that is in the anesthetic cartridges, so it could be just about anything that could maybe cause a reaction. The airways of an asthmatic are hypersensitive to certain triggers, and they will become super inflamed. The lungs. Inflammation of the bronchi in the lungs leads to the narrowing of the airways, and they will produce some mucus, and that is what leads to the coughing and wheezing. Typical allergens that might help trigger asthma are waste from household insects, grass, certain types of pollen, mold, and pet epithelial cells. Cause the body to initiate immune response, which then produces antibodies. Specifically, IgE, which is immunoglobulin E, is a specific antibody that binds to the allergens. So it further causes inflammatory response, leading to asthma attack symptoms. So it's like a big never-ending circle. So here are some looks at normal bronchial and constricted bronchioles over here on the right. So your normal bronchioles, you'll notice that you have these nice big bronchioles, which are the air sacs, and then the bronchial airways, which is this right here. And you'll notice that this is nice and open. You have smooth muscle and mucous membranes. And so in an asthmatic, the bronchioles become constricted. So the smooth muscle right here is going to contract this part right here, where over here it was nice and big and smooth. And now here it contracts, and you have swollen mucous membranes, and then an excess mucus secretion can happen, and you can see how this is nice and straight and then this is not. It's kind of irregular, constricting and not constricting at different levels. And so they're trying to breathe through this narrow passageway, and then mucus is also clouding up the area, which is when you hear the wheezing and the coughing. So these can be from air pollution, chemicals, industrial compounds. If you happen to work around certain allergens, you can have exercise-induced asthma, asthma from stress, and childhood infections. So the most common types of asthma is the extrinsic. Extrinsic over intrinsic. Extrinsic, of course, are triggers from outside of the body. It's at least 50%, or actually more, a little more than 50% come from extrinsic. It's inherited. It could be pollen, ragweed, any of these types of allergens that are from outside of our body, in the air, etc. Or they can be intrinsic. These are for people kind of over the 35 years of age that never had asthma before and then all of a sudden develop asthma. And these can be triggered by psychological or physiological stress, maybe dental appointments, etc. would cover this. Then you have drug-induced asthmatics. NSAIDs are like ibuprofen and aspirin. Metabisulfite you'll be learning in anesthesiology class, is a preservative that is put inside cartridges of anesthetic that have a vasoconstrictor in them to prolong the shelf life. And so people can have an allergy to that, or just the sulfites from foods. Out in the grocery stores, they would always spray the produce section with sulfites because it makes it nice and shiny and green, and puts the yellow in the yellow and the red in the red, and it preserves the food out there. So you can have exercise-induced, and mainly this is from cold air inhalation. My oldest daughter has asthma, and when she was growing up, she was very athletic, played almost every sport, mostly soccer and basketball. But when the cold air would hit, and there'd be all of a sudden a cold snap, you could pretty much count on her getting an exercise-induced reaction to that, because we lived in Texas at the time, where you have all year-round sports due to the weather, and it would get just slightly cold, and they would be out there practicing, having double practices during a day or something, and so she could get it from exercise. Or infectious, viral infections of respiratory tract. Treatment of the infection then reduces the asthma. Always they'll treat what the infection is first. They'll relieve the asthmatic symptoms for sure, but they need to have you get rid of the infection, a viral infection goes away, and a lot of times the asthma kind of goes along with it. So signs and symptoms: some individuals suffer chronic respiratory impairment. It's just all the time. Others are intermittent, marked by the symptoms caused by the triggers. So it could be like that cold snap that maybe you'd have it in the fall and the winter, as it's like warm one day and then it gets real cold, and then it warms up a little bit and then gets real cold again. And each time you'd have a cold snap that can produce a reaction. Attacks triggered by infection are very gradual. They come on very gradual, but they may have a longer duration. because it takes a while to get over a viral infection. So attacks triggered by an allergen are very acute. They're very quick onset, and they have a shorter duration. All you have to do is remove the trigger involved, and their attack will be better and subside and often go away. So signs and symptoms of a mild asthma attack. You can tell the respiration is difficult. The respiration rate is slightly faster than normal. The normal range would be 12 to 20 breaths per minute, and they may have more like 21. 22 breaths per minute is labeled tachypnea. Then we need to pay more attention to that. Complete sentences can still be spoken though, and they may have mild complaints of wheezing, cough, shortness of breath, tightness of the chest. Their skin color is usually still good, and a lot of times on these type of patients, when they're in your office, you can use nitrous oxide to calm them down for any kind of mild or moderate. So people think that you can't have nitrous if you have something with the breathing, and what that is, it depends on what it is. If it's from asthma, an asthma attack is very calmed. All your smooth muscles calm down, and so you remember that those smooth muscles in asthma attacks of the bronchioles and airways will constrict, and so nitrous helps to relax them and open up those airways. So nitrous does not affect an asthma patient unless they're in a full-blown asthma attack. I probably would not put nitrous on them right at that moment. Respiration is moderately difficult for a moderate attack. Respiration rate may be a little faster than normal, and you can tell it's getting a little bit worse because only phrases or partial sentences can be spoken, and they may have a little more complaining of the wheezing, coughing, and tightness of the chest. Their skin color could be normal or kind of going a little pale. It's slight to moderate drawing in of the rib muscles necessary to breathe. So if it's a little kid and they have their shirt off or something and they're trying to breathe and you see their rib cage draw in order to help them, and it's just slight to moderate, this can be a slight to moderate asthma attack. A severe attack, the respiration rate is going to be very fast or very slow with a lot of distress. Maybe only single words or very short sentence could be spoken. They get very scared that they're not going to catch their next breath, and they will have severe complaints of the shortness of breath, tightness, cough, or wheezing. And their skin color now is really poor, and they're not getting the level of oxygen in their body, and their level of awareness might even be decreased a little bit. So treatment of an asthma attack, if it's during your appointment time, you're going to terminate the treatment, take everything out of their mouth. You're going to position the patient upright, because anytime this person is having an issue, as we've said before, with breathing, we want to position them upright and help to spread out their chest a little bit. So that's why we'll put their arms forward in front of them and position them upright. And so that's going to allow the chest to expand and get more airflow into the lungs. You can self-administer their own bronchodilator, and so they want to inhale slowly and exhale through pursed lips, and so they're going to want to do it really fast. And sometimes when you take 2 puffs, the first one, they're not even really maybe getting the full amount into their lungs because they're trying to do it so fast to get relief. So you want them to try to do it more slow and exhale through really pursed type lips. If the patient doesn't have their own inhaler, we can use one always from the emergency kit. But in most offices, as I've said before, you should have a person designated to make sure that they go around every so often and check the emergency kit for expired things in there. And so when a person has their own inhaler that they're bringing with them, it's not going to be expired. They're going to make sure that theirs is ready to use. So that's why we usually say let them use their own. Albuterol is something that was always recommended. A lot of places are stopping to use the use of albuterol, but an albuterol-like replacement is there. So the inhaler, you take 2 puffs for fast acting and long duration, and they consider long duration of action to be only 4 to 6 hours. So it's not like it's a full day or anything, but they consider 4 to 6 hours to be longer acting. So if the asthma attack doesn't go away, then additional doses should be administered at 15-minute intervals. And a lot of times, that's particularly on children, spacer device and is really good to use. And the EMS should be contacted if this is happening in 15-minute intervals, because we don't want them to go into a total obstruction of the airway, which would be the status asthmaticus. So the maximum dosage of albuterol is 12 inhalations per day, and at 2 puffs each inhalation, that means it's 6 times a day. So you could use that safely at least 6 times a day. But if someone is needing to use it 6 times a day, they need to get to a doctor. So this would be a picture of a patient using an inhaler during an asthma attack. And this is the spacer. So they should bring their own inhaler, like I said. That will be this, and then you put the end of that into a spacer device, which is this. And especially for children, if you just have them put this in their mouth and breathe at a normal rate after you've pushed this down once, then none of it escapes. It just takes a little longer to get there, and but none of it escapes, which sometimes they will be in such a panic that they will have their throat closed a little bit, or trying to swallow, or almost gagging because they're trying to take a breath, and that's when they push it down. So it's going all over their teeth and the roof of their mouth, maybe coating their tongue, but it's not getting into their lungs. So the spacer device helps, is what that's for. So something else you can do is administer oxygen, 4 to 6 liters a minute, if they are in need of oxygen. They always monitor the vital signs, and if the conditions worsen, they may even need an injection of epinephrine. And if they use an injection of epinephrine, they'll always use 0.3 milligrams of a 1 in 1,000 solution. So the continuation of treatment is determined based on the severity of the attack and the speed of recovery. So if you will look in your chapter, at this particular chapter, always after the chapter is over and you go through the questions, then the following page is always going to have that repair page, where it will give you a shortened signs and symptoms and positions of the patient and the treatment that you're supposed to give them. So you can look at that. And that should take care of the asthma.